Well, good afternoon, folks. I'm Michael McGinnis from the Institute of Medicine, and it's my pleasure to welcome you on behalf of the IOM in anticipation of Victor Zhao, who will be adding comments later on. But this gives me the great privilege to underscore my thanks to this extraordinary committee, the committee that developed the report Vital Signs, Core Metrics for Health and Healthcare Progress. We have a wonderful representation of the panel, including Dr. David Blumenthal, who did a superb job as the chair of the panel. So I'm going to pause for a moment, ask David to come up and start the proceedings. We may interrupt when Victor Zhao, the president of the IOM, comes in. Since he's on a tight schedule, we want to make sure that he has a chance to speak to you as well. So, David?
I'm gonna cede my place, my 5 minutes to Dr. Zhao.
I think he was going to tell a joke to keep guys all entertained. Thank you, David. My apology for a little late. So, good afternoon. It's a great day for us, as you know. You may or may not know that we just released, and I don't mean to hijack this meeting, but as you know, with the National Academy of Science members have voted that the IOM is going to be the National Academy of Medicine. So that's a very important step for us. Anyways, thank you all of you for being here in person, and those of you on webcast and joining us today. We learned about the message of what I think is a very important report from the IOM, the Committee on Core Metrics for Better Health at Low Cost. I want to welcome all of you for the release of this report, and I'm delighted the chair of the committee, David Blumenthal, president of the Commonwealth Fund, as well as several committee members are joining us today. Before I begin, I'd like to thank David for his leadership of this top-notch committee, as well as the distinguished committee members who have contributed their very best thinking to this report. Along with David today are committee members Diane Dooley, the Secretary of California Health and Human Services, Elizabeth Mitchell, CEO of the Network of Regional Health Improvement, and our HI, Craig Jones, the Executive Director of Vermont Blueprint for Health, and Sally Oken, the Vice President of Patients Like Me. Now, we also have an extraordinary panel of national health leaders here today. I'm looking forward to hearing their thoughts about the ways the committee's recommendation might be most helpful moving forward. In alphabetical order, they are Georges Benjamin, the Executive Director of the American Public Health Association, Dan Crippen, the Executive Director of National Governance Association, Paul Jarvis, Executive Director of Association of State and Territorial Health Officials, ASTHO, Jim Madera, the CEO of the American Medical Association, Richard Umderstock, the CEO of American Hospital Association. Thank you, all of you, for being here. Truly appreciate it. I also want to recognize the tremendous work of the staff who worked tirelessly on this, particularly Study Director Elizabeth Malfris, Senior Program Assistant Liz Johnston, and Executive Director, of course, Mike McGinnis. Thank you. Now, this study was conducted in the IOM's Executive Office with the impetus for the study generated by the IOM's Roundtable on Value and Science-Driven Healthcare that Mike McGinnis runs. The study was proposed by the Robert Wood Johnson Foundation, the California Healthcare Foundation, and Blue Shield of California Foundation. I'd like to add my thanks to them as well. Peter Long, the president and CEO of Blue Shield of California Foundation, Rachel Wick, program officer, Blue Shield of California Foundation, Maribeth Shannon, director of market tracking, California Healthcare Foundation, and Ann Weiss, a director at the Robert Wood Johnson Foundation. Now, in 2012, the IOM released a landmark report, Better Health at Low Cost, which laid out a path towards a continuous learning healthcare system in America. With its focus on ways to streamline and quicken learning processes, the report being presented here today builds on that foundation work, the work of many others in the field. Let's talk about what got us here today. We know that it's tremendously important for us to measure the performance of our health systems. And certainly, in the past few years, we've seen folks make effort to improve how we measure quality and cost of our healthcare. But being recently the CEO of the Duke Health System, I've seen that these measurements can be also burdensome as well. Clinicians are spending more time on data collection and less time sometimes speaking to their patients. And health systems are spending huge amount of money collecting data, and not all the data talk to each other. I think you know in the report how many thousands of metrics one is measuring now in the health system. And I remember many, many complaints and concerns in our organization at Duke of the time spent and the question of the value added in, of course, wanting to do the right thing for our patients. And every additional measure of every additional issue pulls attention towards a more fragmented components rather than the overall performance and results. So this is why I believe this report is so important. I think it may spur a turning point in how we understand the success of our health system. The core metrics proposed in this report would harmonize the very large number of existing metrics. Certainly we hope so. Reduce the redundancy and decrease the excessive burden on providers and health systems. The opportunity for alignment and to widely adopt these measures could help the nation progress toward a better health at low cost. That's what we all want. And I'm confident that the recommendations of this report will lead us on a path towards that particular better health care, low cost, and engaging patients. So with that background, I'd like to turn things over to Dr. David Blumenthal, chair of the committee, and I really appreciate what he's done for us as well as the committee. I personally believe, having been in the front line, that this is so important for our nation, because by emphasizing the things we need to measure, by harmonizing and coordinating them, we can truly not only reduce the burden of the workload, but actually having an even better impact. So David, thank you very much.
Thank you, Victor, and congratulations on the achievement of the integration of the Institute of Medicine into the National Academy of Sciences. I want to thank the Institute of Medicine for giving me the opportunity to do this, and also my committee members. There are several of them up here, but there are also quite a number in the audience. This was an absolutely spectacular group of people that it was a privilege for me to work with, and I also want to second Victor's commendation of the staff. The staff at the Institute of Medicine always bears the brunt of the work and is responsible for so much of the terrific work that the Institute does. We have a lot of disagreements in the healthcare area in the United States, but it seems there's one thing we are growing more and more to agree upon, and that is the importance of measuring the performance of our health system and doing so accurately and tying that performance to rewards that are received by providers of care throughout our country. This message was resoundingly delivered by the bipartisan legislation that was recently passed, H.R. 2, the so-called Doc Fix legislation, which was, in my view, much more important for the future it envisioned than for the problem it corrected, a future in which the nation's physicians are rewarded for how well they perform. It is to help with that process of measuring performance, I think, that this committee was formed. It didn't anticipate the legislation precisely, but the legislation was well timed. The mission of the committee was to, in a sense, provide a framework that would allow the setting of priorities and the winnowing down of the many, many measures that Victor referred to, those measures that have become a problem as much as a solution to the problems of our healthcare system. When you want to winnow things down, you have to have criteria for doing so, and that means setting priorities, and priorities have to be set in light of goals. And perhaps one of the most important contributions of this report is to ground the measurement enterprise in the goals of our healthcare system, and to insist that as we develop measures, those measures be directly related to societal goals that hopefully can find consensus support in our nation's healthcare system. The committee agreed on 15 specific measures related to those goals. Those measures, we hope, will provide a foundation for the measurement process that will unfold in the aftermath of this committee. The committee tasked the Secretary of Health and Human Services with an important leadership role, which she has also now been granted by the Congress in developing the measures that will follow on from the identification of goals and priority measures. I'm going to stop at this point and start with my co-panelists, and why don't we take them in order here, and since Victor's already introduced them, I will just let them come up and speak one after the other. Then we'll have about 30 minutes for questions after they've finished their remarks. Diana?
Thank you, David. And thanks to the IOM. This has been an extraordinary adventure. In the same year that the IOM issued its report, Better Health at Lower Cost, California established a task force that we called Let's Get Healthy California. And we set out to identify what would it take to be the healthiest state in the nation at the end of 10 years. And being a complete novice in the field of metric science, I thought that there were probably scores of measures that we could choose from. Little did I know that there were thousands. And we concentrated our effort on the triple aim as our North Star: better health, better care, lower cost. And what could we measure that would lead to that? We pulled together people from all over California and all walks of life, as well as healthcare. And we came up with 6 goals and 39 metrics. The work we did together at the IOM came up with 15 measures and 39 specific goals. I did a crosswalk between these and found that over half of them are the same. So from California to the IOM and the work that we've done together, I want to say a big thank you. We have some differences, but we're very aligned on the goals of measuring something that will show us whether or not we are healthy. It's been very exciting for me in California to lead the implementation of the Affordable Care Act in several of the domains, not just coverage expansion, but delivery reform and payment reform. In order to really get to this goal of lowering cost, we have to match the payment with the person who saves the money. Many of these measures give us the opportunity to do that as we move away from fee-for-service into systems of care. We have to measure and get to the quality that will show us how to make those payments in the financing reform. So as one state in the union, I am very grateful for the opportunity to coalesce around some themes and some guidance as we continue to reform our measures and refine them and report on them. We're coming up on our 3rd year of reporting, and we're making good progress. But when we started this, we knew that it would be hard to claim that we were the healthiest state in the nation without having some national goals. So it was my pleasure to accept the invitation to participate in this important work and show how we can incorporate it. We can take this work back at the state level, refine the goals that we already have, set goals if we're a state that doesn't have any, and translate that at the local level so we can have healthy communities and we can have accountable communities for health, distinguishing between health and health care in this very irrational system that we call health care in America. So I am very delighted with the outcome. I look forward to continuing the work with our foundations in California. Blue Shield Foundation of California and the California Healthcare Foundation have been great partners in California, and I was very appreciative of the leadership that they set at the beginning to bring us to this point of having the opportunity for national measurement. I truly believe that what you measure matters, and we have got the skeleton set here now to build on and to make this real at the organic level from the ground up, state by state, county by county, organization by organization. It was hard. It is difficult to choose, and while any of us may wish that there one measure or another, I think if we can align around the themes that can roll up into a determination of our nation's health, this will have been work well worth doing. So I want to thank the IOM and particularly David Blumenthal. His leadership was extraordinary, and I'm very glad to be with you all today.
Well, first of all, also I want to thank the IOM and Dr. Blumenthal for the opportunity to be part of this. It's been an incredible journey, and as you can imagine, it's not easy for people to agree on measures in any group, and this was a big challenge. But one of the things I'd like to add to this, or underscore really, everybody's pointed it out, is the importance of core measures for driving a health system. They become the currency, they're the key ingredient. And all across the country, you heard from California, it's the same in Vermont. Activity to select core measures, begin to organize accountable care organizations and now accountable communities and health systems to improve against those core measures, line the financial incentives up against those core measures, and all of a sudden you see people working together in a new health system way to improve against those measures. And that's happening. It's happening in experiments all over the country. This offers an opportunity to begin to put a common set of measures to help guide that activity all across the country. It's a big move. And if these measures become employed and they help drive incentives, we will begin to see changes across the country. It's a way of setting benchmarks. It's a way of really driving health system reform. Imagine you live in a community where your medical providers, social services, community organizations like Boys and Girls Clubs, public health district offices, we're all working together to improve graduation rates. And we're all working to improve the rate at which kids go on to secondary education. Setting that benchmark, tying incentives to it, feedback, learning health system activities, this is becoming real. And so this takes a big step in helping to formalize it, and it's been an incredible opportunity to be part of it. This does drive the currency of a health system. And I also want to underscore that when you look at the measures, this clearly is not a healthcare set of measures. This is a go at a set of health measures, improving the health of the nation. So hopefully it will become the start of using core measures as a glue to build health systems. The leadership it took to guide this crew through this was incredible. We have to acknowledge the IOM staff. I actually don't know how they came up with this out of all the different meetings and debate and discussion, but that's actually the proof of concept, that it can be done. And also, it isn't about whether you have the perfect measure or not. In Vermont, As in California, I'm sure we're finding if you take something important and you organize people working together, there's a whole array of sub-measures that come under it. So you want to improve graduation rate? Well, in our community health system, you'd really have to be screening for adolescent risk behaviors. You'd really have to be doing something about it. Adverse child events. There's a whole array of things that fold into what looks like a simple measure. It isn't. But you're not going to improve that without getting those people working together. So this is the glue for that. And I want to again thank the IOM for the opportunity to do this. It's an incredible next step in America's evolution and delivery system reforms. Thank you.
So I, too, have to send my gratitude for the opportunity to be a part of this very august group. As an employee of a company called Patients Like Me, we are all about patients. And one of the most important questions we try to help patients answer on a regular basis in terms of the measurement that we help them to do is, given my status, so how am I doing, what's the best outcome I can hope to achieve, and how the heck am I going to get there? And, you know, there haven't been a lot of answers to those questions from the system measures that we pretty much have come to know, and sometimes not so much like, over the years. But I think one thing that was a priority for this particular committee was that we were going to focus on engaged people. We were going to focus on how can we have people getting engaged in their health, understanding what it means to be healthy, and then interpreting how to stay healthy in ways that actually fits their lifestyle and their community. So I think the innovative, most extraordinary outcome of this report has been real attention to identifying that we need to prioritize healthy individuals and healthy communities in order to achieve all of these other measures. Without their involvement and engagement and commitment to health, we really aren't able to prevent some of the things that we're hoping to prevent with some of the core measures that we have. We can't ensure graduation rates are going to increase because people, if they don't interpret that as being a sign of being well and healthy and having good well-being, then they're not going to be able to measure how well they're doing against someone else. But I think ultimately, at the end of the day, one of the things that will come from this report is our identification of the fact that patient engagement is no longer a buzzword, and it's not just about patients. It's about engagement in health. And when we begin to put some investment in that and we can begin to measure it, individuals and communities can then be able to say, well, here's how we're doing, here's our status, here's how we're doing against others, and here's some interventions that others are doing that we can learn from. Why don't we start employing some of that? Maybe we can have some healthy foods and farm markets a little more frequently than we've had before. Maybe we can start having some walking trails. Maybe we can get some policy around different ways of being able to ensure that school health is an important criteria for the kids from all the way from kindergarten all the way up. So I think the report gives us a path towards that, but it has also helped us identify the measure gaps that we have, and that we have a lot of work to do. I think one of the things that the committee identified, and for some of us struggled with, was that we didn't have a lot of science behind engagement. We didn't really know enough about it yet to say we had these measures that could help us start to identify how well we're doing. So what the report becomes is a call to action to say, let's get the science, let's build upon what we already know and start expanding that into the communities, get the voices of people who are actually living with wellness and illness issues on a day in and day out basis and bring their voices to the development process. So I'd like to just suggest that we all take a moment and think about our own individual health, our own individual communities. How well are we doing? What's our status? What help do we need? Where can we find it when we start to have these core measures going up and down the system? And at the end of the day, start thinking about how we hold the systems accountable to meeting the goals that we mutually have, and that's to create a culture of health within this country. And I think in order to have a continuously learning system, we can't do it without involved and engaged people and the communities within which they live, work, play, and otherwise spend their time. So it's been an incredible honor to be a part of this project and to be a part of this report, and I'm really looking forward to the opportunity to hearing people's reactions to it and understanding how we can all work together to accomplish the work that the report has set forth for us. So thank you very much, and thanks everybody for your participation in this.
Good afternoon. It is such a privilege to be here, and I want to thank the IOM and my fellow committee members. And despite disagreements, I think we all came out with great respect and fondness for one another, so that's a success. Thank you. And my name is Elizabeth Mitchell. I run an organization called the Network for Regional Healthcare Improvement, and it is a network of over 30 regional collaboratives working at the community regional level with all stakeholders to transform care: employers, physicians, health plans, patients. And I would say from my experience working on the ground, no one did this on purpose. No one set out to create chaos of measurement or the cacophony that we are living in. It was really a lack of high-level leadership and alignment that until now was absent in bringing this issue to the forefront and saying the burden is too great. We have to do something different. So we not only have to align across federal programs, and we know CMS and HHS is leading that effort now, but also in the private sector, and then ultimately for population health across both sectors. This has to be public and private alignment. So we're all going to have to give up some of our favorite measures. We might have to change some of the things that we have been doing. And it's going to take more than measure standardization. We're going to have to actually standardize implementation. So we have had the opportunity to work on the ground to actually develop common measures across regions. And it's not just the measure set. An off-the-shelf measure with the same specifications is often implemented differently in a variety of settings. And it comes down to data access barriers, or different populations, or business restrictions, something as banal as a vendor licensing agreement with a certain risk adjuster that you can't change to compare across populations or settings. We're going to have to get into the nitty-gritty of implementation to really get to standardization, comparability, and benchmarking. So what I'm really excited about is that this is front and center, that we are beginning this conversation from the august IOM with the engagement of such important stakeholders at the state, community, and national level. And we are calling on the HHS Secretary and the President to say, we need to do this together, because this is the beginning. We can say we need core measures, but to really drive this change across the stakeholder groups that will all need to do something differently will take a lot of leadership, a lot of patience, trust, and courage. So I would also underscore what Dr. Blumenthal said. The urgency for this could not be overstated. As one of my co-conspirators, David Lansky, said last week, with the passage of the HR2, we're about to reallocate up to $1 trillion. If we don't have transparent, meaningful performance information, how do we know we are doing that effectively? How do we know we will have achieved our aims? For everyone to be successful, not just the providers who are bearing the brunt of the current system, but also purchasers, patients, and communities, we need to move forward together. So thank you for being here, and thank you for being willing to embark on this journey of change. I think it is incredibly important, and it couldn't be more timely. Thank you.
Great. Well, we're on time, thanks to the brevity and incisiveness of our panelists, and we have some time for questions. So, if you have a question, would you please identify yourself as you ask it? And we actually have microphones available. Obviously, the report is self-evident. Yes, ma'am.
I'm Director of Quality Measurement at CMS, and you mentioned the HR2, as did Elizabeth. So what would you all like to see us do with this report? How would you like to see us use this report, particularly as we are working to stand up the MIPS program, alternative payment models, and so forth? How would you like us to use this?
Great question. And obviously a tough one for you to answer. I think that the part of the, and I will answer very briefly on my own and let my panelists chip in. What I think first and foremost this report does is call on the Secretary to lead a process of measure development that is consistent with well-established goals and reflects, if she or and the administration wishes, the goals laid out in our report and the key measures that were laid out in the report. But I think that we came to the recognition that since goals drive measures, and goals are set in a process that is political with a small p, there needs to be political leadership of the process of goal setting. So I think that what I think is required right now is for the Secretary to outline a process that she thinks and that CMS thinks and that the Congress thinks will work to get to measures that reflect the goals and hopefully the specific metrics that we outlined. Other thoughts?
So I guess just one of the things that struck me through the course of this was I would love to see this really spirit action rapidly, not die an academic death, and in the measure world, which can happen. So in the CMS example, if all of these were tied to actual financial incentives, as you're stimulating, which you are, accountable health systems of one form or another all across the country, will those accountable health systems have built into the financial structure incentives to get people to work together in a way that improves against these types of measures? That's core. Will the Secretary be able to achieve a level where not only CMS, Medicare, and Medicaid money, but maybe money from other entities such as public health and CDC or housing is linked into improvement against some of these core measures? Will money that's going out to stimulate enhanced use of health information technology and the development of data systems, will that money in part being tied to the capture, exchange, and use of elements that are involved in core measures? So CMS, as part of the larger Health and Human Services environment, has an extraordinary opportunity, just like you've done with your core ACO measures. You've stimulated activity all across the country. It's proof of concept how selection of core measures can drive activity. Will that same direction, will that same vision be applied to these broader core measures?
Yes.
Dr. Jennifer Trilk, University of South Carolina School of Medicine, Greenville. I actually have the privilege of teaching exercise and lifestyle medicine across all 4 years of our undergraduate medical curriculum. We work with Greenville Health System. And Sally, applaud to you with what you discussed with community care teams and having a clinical care team that bridges with a community care team. Teaching the medical schools this, we've gone as far as implementing in an exercise vital sign into our electronic medical records and teaching. So I'm loving what the core measures are with obesity and preventative services. But just asking where we can go to further implement in medical education to teach medical students who are our future physicians to be able to service our communities and our nation with overweight, obesity, preventative services, and other ones based on teaching. So what can we do to drive this forward nationally?
I think one of the most important things is to recognize that this is a team effort, and that as much as medical schools and medical students will have a role in this, that we have to recognize that there's an interprofessional experience that has to occur. And that can be at licensed level as well as non-licensed level when you start moving into the community. Recognizing that the contributors to health and well-being are going to be unusual and non-traditional players, and understanding how to identify them within the individual communities is going to require you to get people from the community to help you understand who those people are. So I guess I would say try really hard to come outside of the walls, get into the dirt, into the spaces where people are, and start to ask those questions. How can we help support the health of your community, and how can we teach people how best to do that? And I talk often about people and patients, as well as people and individuals having a fluid role of being a learner as well as a teacher. And I think a medical student will have the same type of opportunity to be a teacher as well as a learner. And I think if each of us takes on that persona and looks at these and says, how can I improve either my own personal health through different measurements that I'm going to start doing, and then bring that to the point of care with my provider to help me better understand how to make the best use of this, and have them be able to bubble up their metrics to meet some performance measure, then these things start to bubble up and bubble down and then bubble across, right? So I think that you have to get that sort of level of interest in understanding that this sense of health is so, it permeates everything we do, and yet most of us, if we were to say, how do you describe your health, or how do you value your health, we probably couldn't describe it very well. So I guess my main point would be, it's got to be interprofessional and interpersonal, so that you bring people in who wouldn't be traditional players and have them be teachers, and by teaching, they will also have the opportunity to learn. So.
If I might add to that, in California, we've had very active engagement with the University of California, teaching both as providers of care in their teaching hospitals as well as the education. And there's such a trend in the age of people coming into medicine and coming out. When I started in children's hospitals 15 years ago, I said it was about 40. Now it's about 55. And the doctors that are younger than that age are very technological. They're very interested in health. They're very engaged in the healthcare system in a very different way than the Marcus Welbys, of not wanting so much to be the one everybody turns to for everything, but wanting to work more in a team. And I think that team-based care delivery, it doesn't just start with a physician, but that's a really key part of the attitude that they bring to the healthcare delivery, and it's changing very dramatically. And I think the incentives that are created in the Affordable Care Act to move to systems of care and away for fee-for-service treatment and diagnostics, so that there are financial incentives to have a team and to go from promotores and community workers to social workers to behavioral health and substance use, and to have that in a system of care that includes clinics and facilities and physicians and plans. In California, where almost 80% of our Medicaid population is in managed care, and we have conditions on those managed care companies that require them to work with their providers to have care management at the delivery level. And so I think that as the younger attitude about information sharing is quite different than the traditional information, centralized information of another generation. That is changing very much both the way the schools are working and the education that young people entering medical school are seeking.
Yes, sir.
Robert Ratner from the American Diabetes Association. Did the committee consider the core measures as equal, or was there either an implicit or explicit weighting of the measures?
We considered them equal. That was not based upon some sophisticated calculation of potential years of life lost or gained if you didn't meet those measures, but they were closely associated with goals that were equally weighted, and so the measures were equally weighted. I don't know if my colleagues would disagree with me on that. Yes?
I think that to ascribe weighting or priority would make them far more granular than I think our intent was. I think, from my perspective, this was an attempt to set some objectives for everyone who is required to measure something, if they can use these as a filter against which are we getting to something that would roll up into what a healthy community would be, or what a healthy state would be, or what a healthy system of care would look like. So that may be some of the work that we're asking HHS to refine, but that is far more granular than I perceived our work to be.
Yeah, just to quickly add on to that, I think as a starting point, one of the things this does is lay out at least a intent to go at a very balanced array of factors that contribute to health, obviously. And it may be more of a local decision as to priority setting, as David mentioned, into how these are incorporated and how maybe they're weighted in incentive systems. And that, I think, having some flexibility in how they're applied is very important because needs may be different in different communities. And so that's an important factor here too.
Can I add to that? I'd like to just add that these measures won't be adopted or used if they are not seen as valuable by the people who have to use them, the providers, the community members, the employers. So there was the intention of allowing flexibility. What is your community priority? What does your community need? What are the problems in your community you're most needing to address? So by having this spectrum of measures, hopefully a balanced portfolio of measures, it does enable communities to really set their priorities within this framework.
First of all, a great report. This is Mike Deneen. I'm from the Military Health System, Director of Strategy. I think one of the things we struggle with is that when people think of healthcare now, they think of cost, quality, and access as goals. And the paradigm shift to better health, better care, lower cost, maybe better well-being is really challenging. And somehow being grounded in those ideas before moving directly to the measures may be helpful, possibly. And as I look through the measure set, there are 4 in there that are fairly traditional, but this is profoundly transformative if we move to well-being truly as a measure and engagement truly as a measure. I applaud your work, but I'm just struggling with how we would implement this in an environment that still thinks of measurement of healthcare as cost, quality, and access. And so I would ask my question, what would you like the military health system to do with your report?
Just to follow up on your question, and one of the things that's impressed me in certain areas around the naval, well, in my particular case, knowing a little bit about the naval health system, is the focus on wellness, but calling it readiness. Right. And so don't these, the question back is, don't some of these measures really fold into a fuller context of wellness or readiness?
So I apologize for standing up again, but we've actually adopted the triple aim and made it the quadruple aim. And so our aims are improved readiness, improved health, improved care, and improved cost. As I was going down your list, they would map precisely to our strategy map for our strategy, but it's still getting that across to people to see that, you know, how you expand the team to everyone who needs to be involved to accomplish these measures. It's not just the healthcare team, it's the whole community.
Satisfying to me that you recognize that. We spent a lot of time in the committee on the idea of readiness and talked about even using your language of readiness. So it's very satisfying that you recognized that.
I want to say that as well because it was an area where we talked a lot about that and tried to think about can we apply the notion of readiness within the core measure set itself. I think what we ended up coming away with was engaged people and in communities were really the important piece that we needed to set our goals for, but that readiness to be engaged and readiness to be an engaged individual or community was really going to be where the challenge was. So I think you raise an incredibly important point. How do we ready ourselves and the systems and the individuals and the communities to start thinking about health in a very different way, in a way that suggests that we all have a contribution, we all have a role and a responsibility to the degree that we're able, especially for patients, but how can I ready myself to be more a part of that and then be able to hold not only myself accountable on some measure to the outcomes, but the rest of the system and others who are involved to the outcome. So I can't tell you how much your insight as the military gave us some insight on that readiness notion, but we've sort of took it a step back and said, well, our goal will be engaged people and communities, but they're going to have to get ready for that. So whether that's getting ready by helping people with literacy issues or other kinds of things, it's really almost a gauge of how do we ready our community to be more healthy.
Could I just add
Sure.
One step towards that readiness and changing the conversation? I believe, is through multi-stakeholder dialogue. Because when you ask people what they want, it rarely has to do with some of the measures that we're talking about. It is about, can I go to my kid's baseball game? Something meaningful to their lives. And when you bring them into the conversation with physicians, with employers, with the rest of the community, it really does sort of reorient the thinking towards a very different set of objectives. And I think that's a very important forum to think through in that transition process.
Let me add to those comments by noting that the military is a big purchaser of private health care. It would seem to me very important, if you want to maximize the efficiency and effectiveness of measurement, that you work closely with the Department of Health and Human Services as they revise and devise their measure sets. That agreement between you and the Secretary of Health and Human Services about how to implement these core measures in terms of more granular measures at the ground level would be enormously powerful with payers and with providers throughout the United States. It would also be very important in terms of the development of your information systems and what you choose to collect as you develop your new information systems, especially if you coordinate, again, with the VA. So I think there's a big opportunity to take these goals, the measures associated with them, take them in the next step to a level of granularity where they can be applied at the local level, and through agreement at the federal level, materially change what happens at the local level. Other questions? Yes.
Gary Pittman from the Public Health Institute, and kudos to the committee. You did a great job, and I think you really hit the right level for these goals and metrics. I think the challenge, as you were just saying, David, is to figure out how do you push them down to the level of granularity needed at the community level, and also the kind of training and infrastructure. Did you discuss how that next step might occur once these are adopted?
Well, we recognized that there is enormous variation in the United States, that having a single set of standard measures that makes sense at the Institute of Medicine now might not create a acceptable set of precise granular level measures, that there needs to be a process of consensus building at through multi-stakeholder efforts, guided, we hope, by the persuasiveness of the framework we've created, to measures that are related logically, empirically, to the attainment of the core measures and the goals that they represent. There will, I suspect, when the dust settles, still be variation from region to region in what precisely is measured. I guess the hope would be, and this is me speaking, not the committee, the hope would be that within communities, within counties, and maybe even within states, that there is consistency, standardization, and a reduction in burden that results from that multi-stakeholder process of trying to realize the goals and the metrics that we've laid out. Now, that's not like flipping a switch, but in our incredibly complicated, heterogeneous country, I think that's an acceptance of the way things happen. If you could do it effectively in a more centralized way, there might be some people who would support that. Any other thoughts about that? This was not something that we put down in black and white.
I do think that payment change will accelerate movement. You know, I talked to a cardiologist who suddenly found himself as part of a bundled payment with incentives, and said he started driving around to meet with the different nursing homes and community providers because suddenly that relationship was required. He was being held accountable for performance across that episode. So I do believe we can align some of those payment incentives with effective measurement that will move this further faster.
Okay. Oh, yes.
Kathleen Blake, American Medical Association, and congratulations on an amazing report. I don't know how you pulled it off, but you did. So the item that was most startling to me is the measure of high school graduation, but it really does have me thinking now, because a couple of you have mentioned the words health literacy. And so all of us can probably remember back in high school having to take civics and to know the basics about how the American government works and cities and all of that. So do you think that there is a need for us to consider as a nation that there is a basic knowledge, a basic level of health literacy that we should be investing in?
I think Sally is surely going to want to speak to this, but I want to first distinguish between the high school graduation rate and literacy. I think they're two separate issues. The high school graduation is an indicator of readiness for health, readiness for life. And in our California work that we did 3 years ago, we included several social determinants of health, and ours was reading at the 3rd grade level. And they're the same idea that you have to have some basic skills in order to live in a healthy way, not about literacy, health literacy specifically, which we also talked about as a measure. But whether you're reading at the 3rd grade level appropriately or you're graduating from high school, they're both more in the social determinant of health category and not specifically related to what you know about health.
I think it's a great question, and one that we actually did talk some about. I think at the end of the day, my hope certainly would be that health becomes a topic that we talk about across the health span and across the lifespan, so that in the earliest days we start thinking about what's the readiness for health that a kindergartner needs, or that a 5th grader needs, or as someone moves into puberty, what do they need? So that we're not necessarily thinking about the health literacy of people, but sort of their literacy of what it means to be healthy. Health literacy sometimes, to me, makes it feel like you're going to teach me how to talk the way clinical people talk, and you're going to have me give it back to you in a way you think I understand it, and then we'll have some mutual agreement that we all understand each other. And I would suggest that there's probably another way to look at that. In many ways, I think patients can be, clinicians need patient literacy. They need to understand the way people talk about their health, and it's not the same as the way we teach them about their health. So I think, currently anyway, so I think there needs to be sort of this melding of understanding of what does health mean? How do we engender that throughout the course of a child's life into their adulthood in such ways that when they are actually graduating from high school, they are ready to embrace their health as an adult and understand what that means and how they value that and how the community around them supports it. So this is, may sound a bit Pollyannish, but when you start to really go deeper and deeper into this, you can begin to understand that you're creating a culture. You're creating a shift in the way people think about health and care and the contribution that individuals and communities have to both of those, and not just the system being the one that is sort of the provider of care. So we're in this together. So that would be one way of sort of suggesting that health literacy in and of itself, my view of it is a bit too narrow. We need to open that up to what does it mean to be healthy, and then how do we define that? Within that, we will find ways of understanding each other. So.
Last question. Larry, did you still want to?
I'm Larry Green from Denver, Colorado, another member of the committee and a member of all sorts of things. And I'm not authorized to speak on behalf of anybody except myself here. But I want to return to the comments and questions from the Department of Defense and CMS and offer just one answer. Don't do nothing. It is really critical to step out. I was seeing patients with residents yesterday in Denver, and one of my main jobs is documentation for Medicare. And it takes 4 tables that include 6 columns and I think 21 lines for me to properly justify payment to Medicare. Please don't miss the opportunity after the recent legislation to rethink, look at what Medicare and the Department of Defense requires in terms of reporting. Stop requiring anything that you can. Replace what you can with these measures, or the data that will build these measures and get us there. There is a desperate cry for relief, for reporting, that does not get us to where we want to be. So a little action, some leadership, and another thing is we've got to steward these. We do not have the stewardship framework in place, but I think Medicare and the Department of Defense and other people in the room have the capacity to develop a stewardship system to get to the vital signs in these core metrics. And Lord knows this would be just a wonderful time to start.
Well, at that, I'm going to ask Mike McGinnis to come up and introduce the next panel.
Well, thank you once again, David and panel committee members, both here and in the audience. I'd like to invite up the second panel to the table here, and we'll move to the discussion of implementation of the vital signs that have been laid out so nicely by the committee. Just to underscore and revisit 3 or 4 things that were mentioned in the course of the conversation of the last few minutes. First, the notion that we are moving to systems of care and systems of health. There is a deep appreciation that's growing about the fundamental importance of looking at the way things work in a systemic fashion. Secondly, we heard that the state of play with respect to measures of the various elements in the system is chaotic. It's fragmented, it's random, it's growing by leaps and bounds in a totally unstructured fashion, and it has to change. And thirdly, we heard that we have to have standardized measures that reliably reflect system performance. One of the committee's charts, if you can't read it, but you can get the gestalt for the middle chart over here, laid out the current measurement burden that society is contending with. And if you look at the bar on the far left, you'll see that what is intended to be reflected there are the hundreds of measures that are currently required in those arenas that the committee just discussed. Healthy people, quality of care, lower cost, and engaged people. Moving to the right, the next bar shows the thousands of measures that are currently required to reflect those hundreds of specific targets because of the inconsistency in which measures are requested and required. Moving to the far right are the 15 core measures recommended by the committee, and just to the left of that are the dozens of, not hundreds, not thousands, but dozens of standardized measures that can be identified through a process that Kate Goodrich and her colleagues at HHS can lead to get to the standardized set of measures that add the granularity that can make these functional at every level of our healthcare system, national, state, local, and institutional. That's what the committee has laid out here. And we're going now to hear from an simply extraordinary panel. It's impossible to imagine a group of people who represent stakeholders more vitally important to the health of the American people and more vitally important to carrying forward both the intent and the practical elements required for implementation of the core measures. To my left is Georges Benjamin, who is the Executive Director of the American Public Health Association. To his left is Dan Crippen, who is Executive Director of the National Governors Association. And next to Dan is Paul Jarris, who's the Executive Director of the Association of State and Territorial Health Officials. And to Paul's left is Jim Madera, the Chief Executive Officer of the American Medical Association. And to Jim's left is Rich Umdenstock, the President and Chief Executive Officer of the American Hospital Association. These who are individuals who have deep stakes in the implementation of these core metrics, and we're going to hear from them about their perspectives and the potential implications for their work. Georges, would you like to lead off? And you can either stay there or come up here.
We'll sit here. I think this will be quite well. You know, I spent the first half of my time practicing medicine, clinical medicine, as mostly as an emergency physician. And what's most interesting is that I think back now that I certainly had a core set of metrics that I did on every single patient. And interestingly enough, they were called vital signs. I can tell you there isn't a patient that I did not see either as they were coming in the emergency department or they left, whether I was concerned what their blood pressure was, their pulse was, their respiratory rate, or their temperature. In fact, if, you know, commonly patients would come in the ER and nobody would take their temperature, no patient was allowed to leave until that temperature was done because it was such an essential piece of information. And I can also tell you on the number of times in which when the temperature was taken, it changed the course of that patient's care within the emergency department. Our nation is now having this amazing discussion around something which has now been discovered called population health. Obviously, it's been around a long time, but now we've suddenly really discovered it. And I think if you really think about this set of core measures, in many ways, this is 15 very, very important measures that I'd like to think of actually help us think through what population health really means. There's certainly a clinical element to it, but I'm very fascinated with the social determinants component to this, Mike. The discussion you just had on high school graduation, the economic measures that you have here around personal spending, the idea of trying to think about the economics of this. I probably would have picked economic inequality, but that's, you know, let's not quibble over measures. The issue of thinking about healthy communities and having a real national discussion about what that means. And you imagine having an integrated health system actually thinking and being paid for making sure that community is healthy. And then, of course, we heard this very eloquent discussion earlier on about not only individual engagement, but if you look at the measures, they also talk about community engagement. The readiness for these communities to engage in health is also very important. So I think that this is a goal. What gets measured, you know, gets done. And unless we begin thinking about these as measures that we're willing to step back and do as a population-based approach to health, I don't think we'll get there. I agree with the committee member who said, let's get started. I'll just tell you one quick story. When I was a health officer in Maryland, we required a very small set, 4 or 5 measures for all of our Medicaid managed care plans. And there were things like immunization rates and doing the diabetic eye exam, and we quibbled a lot over and fought over what those measures would be. But we got them done, and Maryland has very clear data which shows marked improvement over time in those individual core measures. But what also happened was they created a real culture of health and a culture of medicine within all of those systems. And I think that's what these 15 ultimate core measures will do for us.
Thank you, Georges. Dan?
Thank you, Mike. And I want to begin by saying in reading this report, there are a lot of adjectives that come to mind. All of them good. All of them good. And some of them have been used today, of an extraordinary piece of work and all of that. I do want to say, though, just in plain language, what a great report this is and what a great piece of work it is. It's something that those of us who have worked either in or on the edges of healthcare have looked for a long time. trying to figure out how one sorts through measures and how to weed out process versus outcome. And you've done a terrific job, I think, of getting to the system-wide measures and focusing on outcome. So I thank you for that. States will be able, I think, to use this report and its product to good ends in the next steps, as you talked about. And why do we care? Diana referred to some of the parts of how we need measures in Medicaid and how population health and Healthy California. But there's almost every aspect of healthcare that we engage in is touched somehow by states. Now that's only a slight overstatement from keeps me employed most days. But we're talking about education and medical school curriculum. States influence that and influence the number of doctors who are being trained and what profession or what specialties are offered and being trained in, but the number of nurses, the number of nurse practitioners, what can a dental hygienist do after they graduate? All of that is in the purview of some aspect of the states. And we need ways to not measure those folks, but measure what they do. We obviously, states are regulators of healthcare insurance. And as Diana alluded to in Medicaid, probably the single biggest thing that states do and can influence how these measures are developed and used is in contracting. In Medicaid is, for some states, the largest health plan in the state, and one of the great ways of influencing how measures are used is contractual relationships with those managed care organizations that Diana mentioned. And so what we require of them, what we require to measure them, and equally importantly, as the panelists before said, how we implement those measures can be heavily influenced by the purchasers. And states are big purchasers. And again, not just Medicaid, but their own employees are a very important part of the healthcare commercial populations within a state. And of course, the retirees. Often retirees and retiree healthcare can be as somewhat problematic and expensive as some of the more costly parts of the country. So as a purchaser, the states have a big stake in and a big role to play if they will take that up. Just a couple of comments, Michael, on the report and things that caught my eye that I think are so important for us to remember and maybe as part of my expressed relief. At one point, I think it was in the executive summary, talked about that your goal as a committee, or one of your goals, was to come up with fewer measures, that they be more focused, and that they be comparable or comparable. I'm not sure which way that goes. I guess it depends on which coast you're from. But they're all three important, particularly the latter, at least from where I sit and for what states need to do. Be able to look across themselves and comparing with each other, but have measures that we can use as benchmarks. I can tell you from time spent as a green eye shade, trying to develop baselines, how you measure change over time when what you're essentially doing is forecasting what the world would look like if you didn't change anything. And then from that point on, we estimate what might change if you actually change things. And so the development of baselines and measurement is a sticky issue. And it's really tough in healthcare. And it's tough not just because outcomes are hard to measure, but it's tough about the way we do our research, and it's tough about the way we practice healthcare. Georges and I have talked in the past about kind of the conundrum of things like having a depressed diabetic. You know, if you treat the depression, they do a better job of taking care of themselves. And we can see that somewhat in the numbers, and we know it intuitively. It makes sense. But we don't have a randomized control experiment in which we have a bunch of depressed diabetics that we're withholding depression treatment for. We just don't work that way. And so how we measure things is critically important, and the ability to compare across groups gives us our best benchmarks. And so it's vitally important that we make things, and as was said, we implement these measures in a way that makes them comparable. I think that as a next step, I would say that thinking from the state point of view, that if we could work together with a number of stakeholder groups, obviously started with including HHS, and focus on Medicaid perhaps as a subset of, and take your report and your core metrics and see how it applies to Medicaid. We've tried to do this a bit in the past with decidedly only mixed results. With our friends at NCQA, we developed, and they developed for us, a set of about 25 measures a couple of years ago that we tried to suggest strongly to states that here's a core set of measures. They don't map to your 15 very precisely. Some of them do, but some are a little off the mark. But suggest to states that here is a set of measures that you might start with. Not to say that they are all the things you want to measure, nor necessarily fit the state perfectly, but starting to do things that make them comparable. We didn't get very far with that effort, frankly, and I'm hopeful here we have an opportunity for us as an organization to restart those efforts to make a core set of measures worked out with the appropriate HHS and other organizations like Paul's to see if we can promulgate kind of a consistent set. Last thing I'll say, most of you are too young to remember a fellow named Daniel Patrick Moynihan. I had great good luck to work with him over parts of my career. And over the course of time, after he would drink some of my scotch, I would engage him in a conversation about Moynihan's laws. And I'd make an observation about, this really seems like something you've said more than once, so can I write it down as Moynihan's law? And after some editing, we'd finally get to some resolution. And there's still a controversy afoot in the nation as to what Moynihan's first law is. And I won't involve you in that debate now, but Moynihan's second law is pretty well understood to say if you want to solve a problem, you first have to measure it appropriately. And if we can't measure our healthcare system, its inputs and its outputs in successful ways, and without good data analytics and good data, we won't get to the solution. And so this is certainly a giant step forward, I think, Michael, in our efforts to do that.
Thank you, Dan. Paul?
Well, I'm going to start out by congratulating the committee and the IOM for an excellent piece of work. In many ways, it's an aspirational piece of work. There is still so much further we have to go with this. In particular, I think naming it core metrics for health and healthcare is important. Health and healthcare are two different concepts. They're related, but they're different, and I see that's recognized in here. And they need to be approached, although in a related manner, often in different ways. The notion of having the Secretary set some goals, and it's the second time the IOM's called for that in the Public Health Financing Report, there was a call for the Secretary to set national goals also, but have those national goals and then create a system of metrics. And I like to think of it as sort of nesting metrics, so that the national metric, state metric, local metrics can add up and aggregate and disaggregate. And then on a horizontal axis, everything from the practice to the community to the public health system. But we have to go much further than that, and a lot of this is Michael's work to look at the social determinants. Again, health occurs in many ways outside of the 0.02% of someone's life they spend sitting in front of a doctor. So really understanding, though, just how complex that is. And again, an IOM report isn't a beginning, isn't an end, it's simply a beginning. And now this is a call to action for everybody here. So many challenges with metrics in terms of, and from here to actually develop validated metrics, which the NQF spends so much time on and is so tedious to do. Timeliness is going to be an issue. How do we get measures? Because the point of measures is to drive action, to drive improvement. If the measures are a year or two old, that doesn't really help us improve continuously. Measures that can be derived at the national level, but also at the local level. There are very few measure sets that go up and down like that. And then we have the issue of measures around social determinants versus clinical measures. I mean, many people who grew up in healthcare like I did, and George and others, were comfortable with clinical measures. Social determinants, those are sciences outside biomedical science. All the other social sciences out there, which frankly I've been in discussions with the clinical sector and often, or biomedical scientists who don't believe that, the economics or political science are truly sciences. So is that valid? Can we enter the conversation here? Well, we've got to. We've got to learn to work with those other sciences to truly figure out what the social determinants are. A particular point I want to make is the committee established health disparities as a cross-domain priority, and I think that's incredibly important. We tend to refer to health equity as more of an aspirational term rather than a deficit-based term, but as reading through the report, there are many places in which there's a measure and then there's an equity measure. The World Health Organization's concept of goodness and fairness. Goodness is the overall measure in a population. Fairness is what is the gap between the most and least affected population. And again, aspirational, the committee set this as something that would be done at each measure level. And I think that's very important. And we have to be incredibly determined and relentless at making sure that happens. Because even as we listen to the airtime in this meeting, health equity has come up very little, despite it being a point that you made clearly in the report. Personally, I don't think we're ready in this country to go to a place where we only consider it something to be considered at every measure level. I think we need an aggregate or a larger measure on health equity so that we can make comparisons of states, of localities, of health systems to really focus on health equity. And at the same time have a measure for each, whether it's infant mortality or housing or high school education, all those things where there's huge disparities and gaps. The measures of engagement. How would you measure engagement in Baltimore today? There are very many different communities engaged at very different ways. So that again is why we have to have what's the overall level of engagement, but what are the differences in these communities, because it's so different. So with that, I want to congratulate you and say that we're willing to join you with this, willing to, at the state health agency level, willing to struggle with you in this. And I am just so, and I've worked with NQF and the folks there, and I feel like the first body to hit Normandy and hoping other people run over our bodies to get there. This is so surprisingly complicated and difficult, even when we think we understand the concept. So we all need to join in here. Thanks for your great work.
Thank you, Paul. Jim?
So, Paul, we'll be right behind you.
Step right here.
Well, I also wanted to congratulate the committee. This was both important and exciting for the American Medical Association. And just to preface why, we want a strong nation, and when we think of the broad aspirational goals of healthcare, lower cost, it was almost broad enough to be a simple tautology with wanting a strong nation. At the same time, I want to measure things, and I'll mention something about our role in that. But what one was missing was a crosswalk, kind of a roadmap that allowed one to go from measures that were sub-measures to something that captured this high aspiration. And these 15 core measures give us that roadmap. So I think that's incredibly important. Critical and opportune, critical, we're still spending a lot of money. We're not getting the outcomes we want. Opportune, it is, I think, true that the measures today are too complex, they're costly, they're very uneven across the system. They don't really promote shared accountability. They're very siloed. That we also believe that, this is everyone's business, and accountabilities have to be broad and shared because everyone in the health system really touches these. So the vital signs, we feel, are really a step forward. I should also say that we've done in the last 2 or 3 years 2 lengthy collaborative studies with Rand Health. And one was recently published last October looking at physicians in the setting of changing payment and delivery systems. And what we found just really reflected what's in the committee's report. Too many measures. Practices were overtaken by the tsunami of measures. And in fact, we found practices where the leaders often resorted to shielding their colleagues from this measurement tsunami. And interestingly, what often would happen is that the physician group would identify evidence-based measures and spontaneously use those that were related to their patient population. I think Elizabeth brought up this point about believing. And what we're finding in these studies is that when physicians believe, they act, and that is a powerful incentive. So we're really pleased that the committee focused on what we have found, too, of the critical issues of fragmentation and burden. should step back and say that the AMA convened the Physician Consortium for Performance Improvement in 2000 for measure development. About 300 plus 350 measures were developed, and many of those measures highlighted in the report actually came from PCPI. Happy about that. Also, pleased that the report highlighted the importance of dealing with hypertension and diabetes. These are two areas on which we focus. Sally brought up this issue of non-traditional partners and the community extension. So, you know, people are not surprised to hear that we have partnered with the CDC in these efforts. People are a little more surprised to hear we're partnering with the YMCAs of America in these efforts. And again, sort of a shared accountability across that system. In the last couple of years, recognizing the difficulties and the heavy lift in all of this, we have distributed the responsibility for measure maintenance and updates of existing measures to 30 specialty societies. But again, now the specialty societies have this core measure roadmap to follow, which is incredibly important to us. And we're certainly committed, as are others, to working with the Secretary to bring this to life. This is going to be a long, hard fight. It's really a reformation, a transformation of how we think about our health system. I note in that regard, we've recently been released from SGR prison, so we have some time. Also, that we really need one of the concerns that I kind of read into the report that we share is the adoption of the core measurement set is going to require everyone accepting responsibility and accountabilities as a system. That means medical device industry, insurers, EHR vendors, patients, everyone across all localities working in a seamless way to achieve these 15 core measures, none of which I think anyone can argue with. You can't point to any of these and say, that's not really important. They're all really important. These goals, I think, can also, will need to be assisted by electronic health records that actually function in a way that allows timely availability of actionable clinical data at the point of care for all providers. Diana brought up the issue of timely data, and what we're finding and others like Colstead have found is that one of the greatest incentives for physicians is actually providing this data feedback. So the recent repeal of the SGR has also been important in temporal sequencing with this report. Many people will tell me congratulations about the SGR repeal, but you know, a lot of that bill is really about payment and delivery reform. And it is so simpatico with this committee report that it has to really be recognized and followed. And lastly, I'll say that there are other areas in the social sciences that are going to be so critical. I couldn't agree more. Our board has just released, approved rather, a request for sizable assets that will be used over the next year to start using the 21st century means of influencing populations like physicians. And that 21st century means is really a design-based means. Things that are condensed, they're fun to use, they make points in a visual way, which is also very different for our system. And probably at the end of the day, what will be needed to engage our patients too. in a 21st century way. So again, congratulations on this beautiful piece of work.
Thank you, Jim. Rich?
Thank you very much. Pleased to be here today and to lend our support as the American Hospital Association for this report. It's really terrific work, so we want to strongly support it. Now, Jim and I talked on the way in about, and I've heard a lot of references to HR 2 and new pay for performance expectations and so on. Welcome to our world. This is something about which we've had a little bit of experience and more than a few measures along the way. And we've had, as the report points out, variations on the measures and variations on the variations. And for the last dozen or so years, we've been asking for exactly what the IOM and this committee has delivered today, which is a roadmap, as Jim calls it, a framework for making sense out of this. We're definitely in support of measurement. It helps us get better faster on behalf of our patients and also informs our patients. We've seen the benefits of standardized measures and focused measures, most recently in the hospital engagement network undertaking across the country and the terrific results that that produced. It shows what can happen when we're on the same page. Now, not to be negative, but I have heard a lot of conversation today, being the last one I can say stuff like this, right? There's nobody over here, about what it isn't or what this report doesn't yet address. My God, that is 6 lifetimes worth of work. I'd rather ask us to focus more narrowly on what it is. It is the type of direction, the type of common playbook that we need as a nation. So to the question about what HHS should do, I say I'm ready to pledge the AHA's support to help sync this up with a national quality strategy. Let's not have different variations on the theme in the policy world the way we have them in the measurement world. So let's start to sync this up. We pledge to do our part on hospital-specific measures and our contribution to those measures that measure things outside the direct walls or control of hospitals. In the last year, we took our own members through an exercise asking them what would be the small number, in this case we came up with 11 measures, that would fit very nicely into this that are specific to hospitals, that we should be focused on and that we should be driving about our ownership of this realm of health and healthcare. So we're very ready to sync those up and help drive this framework and to look at the other areas where we can play a strong supporting role and hold ourselves to that. I think the answer to the issue is really to get on the same page, and I can't say it often enough. You've done that. You've given us the beginning. So let's look at this for what it is. Let's hold ourselves as stakeholders accountable to say, what will I do? What will we do? What will we deliver our members to do to keep pushing our areas of interest and need into this framework, which will make us give up some favorite things, as has been pointed out. But without that, we can talk a lot about what's not here and what still needs to be done and so on. I say terrific work, terrific tool. Let's start using it today.
Thank you very much, Rich, and Jim, Paul, Dan, and Georges. Let's open the floor up for questions or comments. We've got a few minutes in that respect. Anybody want to lead off? Yes, Helen.
Hi, Helen Burston, Chief Scientific Officer of the National Quality Forum. Thank you so much. Thanks to the committee. This is a phenomenal amount of work. I did feel like we got trampled a bit trying to do population health several years ago, and I think this really does give wind at our back to say these are the measures we need to directionally go towards. But there is a phenomenal amount of work here, and we shouldn't underplay getting from what are general concepts to measures that are standardized, that not only are standardized at the population level, but ideally would be able to be used to, in fact, cascade up and down and be able to see the different influences, in fact, of what is a hospital, what is the physician's role, what is the community's role. So we really do stand ready and willing to work with our federal partners and others to think about how to make this a reality, because it is so important and the time couldn't be better. Thank you.
Thank you, Helen. Let me ask Paul, as you're looking at the role of a state health officer, much of the time is spent working with governors. And how can the core measure set that's been presented by the committee be helpful in that respect?
Yeah. Well, are you going to listen?
Yes, I'll take notes.
Our folks work for their folks. So I think we're continually looking at the health of the state. We heard California now has come to a Healthy State initiative. Others are doing that. So the question is, by what metrics are you measuring the health of your state? And so I think moving into this, making sure what we're doing is consistent with this will be helpful. One of the things we'll go back and do is we work a lot with United Health Foundation, America's Health Rankings. And so we'll go and talk to them. Very smart people have been doing this a long time about, okay, how are we going to bring this lined up? Because we don't want the governor to call us and yell us one day for one set of measures, the next day for another set of measures. And then from our point of view in public health, where we align in many ways, Million Hearts and others, with the clinical sector, immunizations, but we also are now trying to look at social determinants and working across the cabinet with all the other cabinet areas. To what extent are these going to be meaningful us to sit down with the agriculture, transportation, economic development folks in the cabinet to say, okay, let's start looking at your potential. How do you further transportation, agriculture in a manner that also helps us improve the health? So optimally, it would help us with that conversation. So I think again, we're trying to create systemness where there is no systemness, and that's what's so strong about this.
And George's, you mentioned the importance of community health. If, let's say, Kate and her colleagues, or Don and Kate working together in HHS, are taking the committee's charge, which was in essence to identify the various granular elements, whether it's through composites, and about 7 of these 15 metrics require composite measures of one sort or another. And they've charged the Secretary of Health and Human Services with doing this. The question to George's is, on the community health measure, what kind of process would you like to see Don and Kate orchestrating that would ensure both the adequate input, multiple stakeholder input, and factor in the key elements that are most important?
Yeah, I think, hi Don, how are you? I think that the getting the input from a range of stakeholders, as you said, is important. So that means community-based organizations that are doing this kind of work today, public health associations that are linked to the community. We know there are a range of consumer groups that today are involved in this kind of work. I think you want to make sure that the groups that you also bring to the table, Jim talked about the YMCA. There's a whole range of groups right now that are doing work around the old community transformation grants, for example. They have enormous experience now, 5 years into the Affordable Care Act, into actually going into communities and doing this kind of work. And I think they can give very important input into what measures are really measurable and what those measures actually mean around community health. So they've done work around, building playgrounds and making communities more green and dealing with transportation issues and making sure communities have grocery stores and fresh fruits and vegetables and those kinds of things. So those are the kind of groups that I think I would bring to the table. So I would probably start with the CTG grantee list. Add to that groups like APHA and their affiliates, and then some of the other groups that include YMCA's, boys clubs, et cetera, because they've been doing this kind of work and they have an enormous experience.
Thank you, Georges. Yes, Sally.
No, it just raises a great point that I think I want to reinforce, and that is we all are probably aware of some really excellent things that are happening out there that sort of exemplify some of these core measures, especially at community levels or relationships like you have with the WISE. I think we need to find a way of being able to identify them, sort of begin to maybe create your own inventories of what exists, and then be able to give HHS some guidance to say, well, here's some models. Diana was just mentioning to me that they have a local community-based kind of model. So I think we need to find ways of being able to bubble these up and recognize that there's good stuff being done out there. Let's not replicate what we already have some examples of, and then bring those out and illuminate them in a way that we can start to replicate some of the work already done. That will also help us identify where either there's some gaps or redundancies, you know, start thinking about the opportunities that might exist for some of the measures that we don't have. So I applaud that suggestion. But an inventory of where we could provide examples of really exemplary work already being done, I think would be helpful.
Rich, I'm going to ask you an unfair question here, and that is to pick up on the engagement dimension. And as, again, I'll pick on Kate and Don back there, as they're thinking about how they pull together a group of stakeholders from around the country that can dig into the notion of individual and community engagement, which I know you've been leading at some level in the hospital community. What are the kinds of things that come to mind that, from the hospital perspective, that you'd like to see both in process and content undertaken?
Well, I'd run it out a little bit from HHS and talk about the government, because we're accountable to lots of different entities there. But fundamentally, I'd say start with the question of why wouldn't we use these? Because as soon as we start to break away from these, we build variation, and variation's waste, and we get right back to where we were. So whatever government agency looks at this, why wouldn't we start from this? And then secondly, why wouldn't we use this consistently across programs? So we've got performance-based measures in the patient care area. We've got performance-based measures in the IT area. We've got performance expectations in the community benefit area. Why wouldn't we start with this? And why wouldn't we iron this out across entities? It would make for a much more powerful national push, and it would really lower the frustration level and up the commitment of the people on the front line who at the moment are filling out all of these forms and not seeing some greater purpose in it. And I think the government is a great place to start if we can look at this across programs and areas of accountability. So to each of our government partners, I'd say, why wouldn't we start with this? And I'd say the same thing, frankly, to each of our private payer partners. Why wouldn't we start with this? Where is it necessary to get off track from the beginning, and how can we line up public and private as well? All of that's a lifetime's work, but I think that's the challenge that we have to point to ourselves.
Paul?
Yeah, so Rich, looking at this, all of our local health departments, state health departments do community health needs assessment, community health improvement plans, and I'm just thinking about how this might apply to that. And all of your nonprofit hospitals do community health needs assessments, and I'm wondering what you think about this providing some kind of an alignment potentially between public health and the hospitals in looking at communities.
The more we work off the same playbook, the same outline, the same dictionary, good things might, can't help but happen. Put it that way.
Yeah.
I might add, someone from Greenville brought up a question concerning education. And this also goes to the root of training physicians, that we now have an 11-school consortium where we're trying to break and reformat the structure of medical education, undergraduate medical education, for the first time in a century. But some of the things that happen is when you speak currently to physicians about population health, and you listen carefully, a lot of times what you hear is that for that individual, the population is the 2,000 patients on their panel. And medical schools are very good at instilling advocacy for patients, but currently really poor at having people hold the thought that I will be one of 850,000 practicing physicians. There are $3 trillion in the health system, not a dollar more, and they have to be deployed for the maximal benefit of 320 million people. And that is a very different way of thinking. It also requires ethical underpinning to hold those thoughts in your head at the same time, and our ethics group is, I think, has that nearly sorted out at this time. But some of the perturbations, I think, in thinking about public health also track back to the original training.
Thank you, Jim. Yes.
I was, excuse me, I was just going to comment again, Jim, thank you very much. We do utilize our YMCAs, and it's good to hear that others do as well. We are teaching the medical students and also the physicians at our health system to use the physical activity vital sign. And if that individual has a comorbidity or is under the United States physical activity guidelines of 150 minutes of moderate to vigorous physical activity a week, they are deployed to a physical activity intervention advisor, which is hired by Greenville Health System, where that individual works with the patient on their engagement, on their ability to pay, on any barriers, whether that are transportation or SES, what have you. And then they are referred to our YMCAs, in which the individuals are credentialed with a larger credential than what you would find perhaps at a Gold's Gym or a 24-hour super sport. So all ACSM certified or Bachelor of Science in Exercise Science. Again, just using that bridge of the clinical care team and the community care team.
Thank you. Dan, if I can ask you to elaborate a little bit as we wind down on what you feel the governors can most do to help implement the report of the committee, and what do your colleagues here on the table with you, on the panel with you, what might they do to help the NGA in that respect?
The first step, and I alluded to it only briefly, is to figure out with our friends at HHS what the right group is. I can think of, Paul and I can come up with half a dozen groups representing states, and that would be a critical piece, but certainly not complete. And whether Rich or Jim would want to be involved, I don't know, but whatever the right group is, at least for the first outing, to try and take the 15 core metrics and see how to apply them. I was being a little less ambitious than Rich and thinking about, well, maybe if we could start with Medicaid, it would be at least a more confined discussion. But that does beg the question of then what about Medicare and how does that differ? And so I do understand that. But we need to figure out a process to come up with a set of measures that we can then promulgate, propagate out to the states. And then, to me, the fastest, most effective way for states to implement is for them to employ their contracting powers with their purchases and create the requirement for measurement as well as the specificity about the implementation of it to the extent necessary, so we don't get the variation on implementation that I know the panel was worried about. So in that context, it would be of physicians, hospitals, other providers, of course, engaging with us in the first instance, but secondarily, then actually utilizing the measures in the programs that states contract for.
So, Kate, I think you've gotten an answer to your question. We've heard that the committee has laid out a framework that does engage the most important issues, a framework that deals with the issues from a performance perspective, from a systems performance perspective. And we've heard that, in effect, by laying out the framework with these 15 targets, they've done at least half the work for you. Because we all know how hard it is to argue over this or that measure and what's in or what's out. So now the challenge is to identify the components, the granularity within each of these arenas, and steward the national process to standardize and implement the recommendations of the committee. I'd like to thank each of you for your coming to the release today. I'd like to especially thank, obviously, George's and Dan, Paul, Jim, and Rich for taking their precious time. I mean, these folks really are the individuals who are most important for moving this forward into our communities around the country. And your level of commitment, both of time and spirit, is extraordinarily important here today. And finally, last but not least at all, I would like to thank David and the committee members who are here. We have Craig and Elizabeth and Sally and Diana. And we also have in the audience Julie and Larry and Kevin. And we have Liz Johnston and Elizabeth Malfras, the study director. And if we could ask the members of the committee who are here, along with Elizabeth and Liz, to stand up just to acknowledge your tremendous work. Thank you all. To be continued.